My name is Nadeem Tehami. I am a hepatologist and I also practice pancreatic biliary endoscopy. I'm really honored to be here and giving this lecture, which is dedicated to Dr. Khalid Hassan. I'm sure most of you know him for his contribution and living legendary status. So I have no disclosures to make. However, when we talk about endohepatology, this is an area where there are a lot of gray areas. So when you speak to a physician, surgeon, anyone with a scientific or academic background, they will always question the modalities that we as an endoscopist can offer to help our patients with hepatological problem. So I come from Southampton. Southampton is a small town not far from London, about just an hour drive. We cover most of the southwest of England, providing pancreatobiliary and hepatology services. If you want to remember it, if there's one thing you remember is Titanic, then you will not forget where Southampton is. So the talk, obviously, as title is Dr. Khalid Hassan, who is an inspirational figure known to many endoscopists all over the world. He's a living legend. He was one of those 5 endoscopists who were given Golden Glove Award by Peter Cotton. He's phenomenal. Those who've met him, for his mentorship skills, for his endoscopic skills, for his academic skills, for his philanthropic skill. In overall, I think he's a fantastic human being who is an incredible professional. So in next 10 to 15 minutes, I'm going to just talk briefly about the subjects that have been already touched by colleagues. I'll probably make it more practical, maybe share a few cases with you, give you my perspective as an hepatologist, and hope as a result of this, I'll be able to motivate few of you who are early in their journey. So when we talk about endohepatology, it's not only limited to what we can offer patients with liver disease with an echo endoscope. It is essentially everything else that we can do as well. So we've been doing endoscopies for variceal screening, banding, injections, ERCPs, managing patients pre, post-transplants, and then obviously in the last sort of 10, 20 years when we've started using echo endoscopes to really make difference to these patients' pathologies. But also endobariatrics, in my opinion, is also part of endohepatology, because one of the major disease entity that we treat in our clinical practice is metabolically associated steatotic liver disease. So I think it is also important. However, just in the interest of time, I'm going to keep my talk limited to what we potentially can do with the echo endoscope. So why are we talking about it? Now, this is important. We briefly touched about it, that when we're doing a liver biopsies, why are we doing it? We're trying to figure out what is the underlying pathology. When somebody presents with deranged liver blood test, we've done non-invasive liver screening, we want to check a tissue, because pathology is the only truth known to mankind. Only truth. We really see it, and then we believe on it. But when we do these biopsies, especially fatty liver disease or steatotic liver disease, it's a patchy disease. It's not uniformly involving the liver. So if we end up taking a patch of a biopsy from an area which is not involved, we're not really going to get the real essence of the disease. So it has its limitations. We talk about HVPG, which is a gold standard, but is it truly a gold standard? You've had a fantastic talk earlier telling you why it isn't a gold standard. It has limitations when it comes to prehepatic or pre-sinusoidal portal hypertension. When we talk about HPG in context of a fatty liver disease, steatotic liver disease, patients decompensate when they don't have actually a very high degree of portal pressure hypertension reported on HPG. It does not correlate well with the risk of bleeding, and there are patients who have bled with the HPG of less than 12. That doesn't really make sense when we say a patient has a genuinely high portal pressure, and if they're not a high blood pressure but they're bleeding, it doesn't really make a sense. Again, we know probably there is something else that we'll be able to offer to our patients who require tips in the future. So now let me take you through this case. So this was a 13-year-old girl who was living with her parents on a farm. She presented feeling unwell. She had been growing normally up until that stage. She was not on any medications. She has no known drug allergies. She has no risk factors for blood-borne viruses or metabolic syndrome. There was no family history of autoimmune liver disease. And she was Okay on clinical examination, pretty unremarkable BMI. So far, so good. She had the liver blood tests. Now, I hope you can all spot it's a bit of a mixed picture. It's not purely sort of cholestatic or purely hepatocellular. She had a liver screen, which was normal. So the only thing which was positive at this stage that she had eosinophilia, she had raised IgGE. And her ELF score, which we regard high if it's above 10. So her ELF score was slightly elevated. Platelet counts were still normal. So what happens next? As we do it all over the world, she had an ultrasound scan which reported that her intrahepatic ducts were prominent, spleen was borderline enlarged, and portal vein was patent with a normalish flow at the time. Then she had a fibroscan which supported liver stiffness of stage 16, so made it F3, F4 fibrosis, and gave her a bit of a mild to moderate hepatic steatosis. She went on to have these imaging. All you will see here is that she's got a bit of a intrahepatic ductal dilatation. It's not uniform, but it isn't very typical of beaded appearance that we would see in patients with PSC. So it wasn't classical of what we would expect in that situation. She also had these lymph nodes around her porta, which was quite marked. She had an endoscopy, which did not show any evidence of portal hypertension. She also had a duodenal biopsies because we wanted to rule out eosinophilic gastroenteritis, which was also normal. So what we did, we found those nodes around the porta hepatis. Those are the chunky nodes that you see. Those nodes were biopsied. We took this sample from these nodes in the porta hepatis. And at the same time, we did the portal pressure gradient. Now, another thing that you can do when we're doing the ultrasound EUS is we can look at the liver parenchyma. We can also look at the waveform of the veins because that gets diminished in the patients who have advanced hepatic fibrosis. So she had EUS PPG as well. Her pressure was about 5, wasn't really elevated, and the biopsy was there, which I'll sort of discuss briefly in a bit. I know we've already talked about it. So far, data tells us that this is an approach which is safe, it is feasible. Yes, it has utility when it comes to multimodal assessment, and when we are trying to combine it with other interventions, PPG, or if you're doing a pancreatic biliary assessment, it would probably make sense to do it because then you can give an argument against the cost-effective issue. Now, we, again, I think briefly touched about the KPIs when it comes to the biopsies, looking at the total length of the specimen and also the number of the tracts. So the evidence is out there that, yes, we can provide adequate number of the portal tract and that the length is also adequately provided. We can express the tissue properly, which is, I believe, where the key is. So those who do EUS liver biopsies, especially the nursing colleagues, you have to work together with them in order to make sure that we are able to express tissue properly. You've also sort of, you've been shown images and slides why and what EUS portal pressure gradient is, where you're actually puncturing the portal vein and the hepatic veins, directly taking a pressure and subtracting it. So in our current practice, we mostly utilize it for patients who are undergoing for hepatoma resection, or those we are actually planning bariatric interventions. Now, the word there is bariatric surgery, but this is going to hopefully change with endoscopic sleeve gastroplasty as well. And then obviously patients who have some other indications as sort of briefly mentioned here. The problem there is that we do not have a randomized controlled trial available yet. There is a study going on in 3 major centers called Encounter study, hopefully comparing EUS PPG with HPPG, and only then we will be able to dismantle this myth that HPPG is a gold standard. So as it stands, HPPG remains the gold standard. Now, back to our patient. Again, we had adequate number of core length and the portal tracts were 46, so it was an adequate specimen, not much fragmentation. And then as a result of this, I hope you can all see what I'm trying to get here. So the diagnosis was very obvious in this case. And we concluded that given her history of living on a farm, eosinophilia, one concern was parasitic infection, those nodes, so we excluded lymphoma, parasitic infections. We didn't believe it was PSC. There was no underlying significant hepatic fibrosis or portal hypertension. She was started on treatment for autoimmune hepatitis and she did well. So hopefully this case would demonstrate that in single session, we were able to do a lot for our procedure, especially for a young patient. Now, the difference between a diagnostic and a targeted biopsy is that in the targeted biopsies, we don't have to worry about the actually expressing the specimen properly. We don't really, the core length or portal tracts does not actually matter when it comes to the diagnosis of a focal lesion such as hepatoma. So this case, alcohol-related liver disease, this abnormality in the caudate lobe, biopsied and proved the diagnosis of hepatoma. Now, where the future would take us, should be able to offer EUS-RFA. We offer it to patients who have neuroendocrine tumors, who have metastasis, and those who have got cysts that cannot be resected. But we haven't really started using it for focal hepatic lesions. Now, moving on, what EUS can do, you again all know that we can look at the intramural varices, then trace them to the extramural collaterals and try to look for the perforating vessel, which is not easy in all the cases, but wherever we can see it, we can try to target that with a coil and a glue. Coil actually acts as a scaffold, and then the glue on top of this makes sure that the coil doesn't go anywhere. The main principle to remember here is make sure you use the biggest possible coil, because the coils can also embolize and can go elsewhere in the body, and which is what obviously concern is. So what this case probably demonstrating here is, and my colleague from India, Sahaj Rati, they have got a paper in DDW where they've used, they have offered these transgastric shunt obliteration to 7 patients in 9 procedures, and 6 of them were technically successful and clinically successful. So these were the patients who had originally presented from hepatic encephalopathy, and after obliterating their shunts, they were able to treat these patients' hepatic encephalopathy episodes, which obviously made a huge difference to this patient group. So I think this is where this is going to be a step before we can get to the step of tips. Now, I think everything else was essentially covered in the fantastic talk that we had before. This case, I believe, which actually made a difference. So this was somebody who had come in with, for endoscopy varicose screening. Patient was there. They had their throat spray. So we do a lot of these cases unconscious sedation, had a throat spray, and when these patients were made to lie, their oxygen saturations dropped. And then the penny dropped. In somebody who has got a cirrhosis, who's got platypnea or doxia, I guess you all know what I'm talking about. So this, I think, case, again, I think remarkably done by Sahaj, and you will see the bubbles. So we know then when the bubbles go from sort of right to left, if they happens in for the first or second cycle, that is going to prove that there's a septal defect, that is ASD, but when that bubbles get transformed from one to the other atrium within the first 4 or 5 cardiac cycles, that tells you that there are intrapulmonary shunts, which, as we all know, would prove the diagnosis of an underlying hepatopulmonary syndrome. So EUS-guided bubble echo, very fantastically, superbly done. Now, as I said briefly earlier, that we also use echo endoscopes, duodenoscopes, gastroscopes, and other scopes to manage our patients who have liver-related disease. So in UK, we pioneered EUS-directed transgastric ERCP. I'm sure you all know what I mean with this. Those who've had a bypass surgery and they then presents with choledocholithiasis, and if they do not have their gallbladder in situ. So if they've got their gallbladder in situ, then we do a lap assisted, and if they don't have a gallbladder in situ, then we go for EUS-directed transgastric ERCP. Now, my presentation was not very data heavy, but this paper, I believe, is phenomenal. Why? Because this shows you that we can combine 2 modalities of endohepatology to make significant difference to our patient's care. So in this, what the authors did, they checked portal pressure gradient before and after of doing an endoscopic sleeve gastroplication using a novel device, which I hope we can sort of discuss during the next 2 days. But here what you would see, so this on the left just shows the primary outcome, which is to bring the portal pressure down after having the sleeve gastroplication. And on the right side, you'll see other parameters that the authors looked at as a secondary outcome. Throughout this data slide, you'll see the difference that endoscopic gastroplication made, which was evident, and it was measured before these patients had an intervention. This modality, PPG, can also be utilized in most centers where they're still resorting to doing surgical bypass. Now, just finishing off very quickly, this is what it looks like when we talk about where we are in terms of endohepatology at present and what future holds for endohepatology. So in conclusion, chairpersons, ladies and gentlemen, Interventional EUS is continuing to advance the paradigm of hepatology. It is the future of the liver disease assessment. There are areas where we need more data to convince our colleagues across the board so that we can offer these modalities as first line to most of our patients. Thank you very much for listening.